Welcome back. Today we're going to continue our study of the nervous system with two completely separate subjects. First, the autonomic nervous system, and then we'll move on and look at the cranial nerves, about which you've heard a great deal so far. The autonomic nervous system is one that, as its name defines, is self-naming. We do not have conscious control of this part of our nervous system. It has a general, visceral motor neuron, which goes out to the intestines, to glands, to organs that function at what we call the visceral level. And then it has the general afferent visceral sensory neurons, which come back to the brain, giving information. It's a completely involuntary system. There are some minor modifications of control that we can exert, but actually this is very, very minimal. This autonomic nervous system goes on by itself, does what it's going to do. It's complete control except in times of extremes in fear, anxiety, fight, flight situations, great stress. We can add a little bit to that system, but by and large, not very much. There is some biofeedback methods that have been developed lately that help us control this system, but most of the time we go on doing the things we do under the control of this system without any knowledge or interest at all. First of all, there are differences between the somatic system, the muscles that we control voluntarily, and the autonomic system. The motor activity in the somatic system is always excitatory. So when we do anything voluntarily, we are upregulating or exciting the effector organ. A muscle is at rest, and then we send an impulse that we want to use that muscle, so we excite the muscle to do something. And this is from the message it gets from our conscious brain. The sensory input that we receive is always conscious too. Maybe not highly conscious, but we feel warmth, touch, pain, vibration, and even proprioception, position of our joint in space. So you're not sitting here thinking about the position of your body, but you know it. And if you want to focus on it, you can get that information. And the other part of the somatic nervous system, the one we're not going to talk about today, is that there's only one neuron in the spinal cord, or the central part of the system, between it and the effector organ. So that neuron that's in the lower back that goes to the muscles of your toe has only one connection from the neuron body in the spinal cord all the way down to your toe, making it a very long cell. If we compare that with the autonomic nervous system, the motor activity can be either excitatory or inhibitory. And we'll show you how that works. The sensory input is different because it's almost always unconscious. Extremes of sensation can be perceived if we get to the edge of comfort, but as I've used it as an example before, the contractions of your intestines are totally unconscious until they either become hard enough to make noise, so you hear the noise, or until you have cramps and pain from some pathologic state rather than the normal state. And in this system, incidentally, there are two neurons. One comes out of the spinal cord and goes to a ganglion, that place where the motor cell swells the nerve before it meets another neuron that goes to the effector organ. So it's just a difference in the number of neurons. And these are usually either near the spine or near the organ, and I'll show you which those are. The divisions of the autonomic nervous system are shown in this slide. We have the sympathetic and the parasympathetic, and the reason they're called that, on this side you see the sympathetic nerves all origin in the thoracic and the lumbar regions, the thoraco-lumbar origin in the spinal cord. So that's where their motor neuron begins. The parasympathetic, which is shown on the other side, start either in the cranial area with the cranial nerves or way down here in the sacrum. So they are, if you think across, paralleling the sympathetic nervous system, only anatomically, not functionally. Now, let's review the general side of this by beginning with the parasympathetic system. First of all, always link it in your mind with rest, recovery, relaxation. all of its functions tend to be rest, recovery, relaxation, and therefore most of the time it's going to be an inhibitory pathway. When neurons send their signal to the effector organ, it's going to do something to downregulate or inhibit that organ's function. It's mediated at the synapse by a drug called acetylcholine. Acetylcholine is wrapped in little packets at the end of that nerve ending, and it floats across when signaled by the nerve to the other side, hits that motor neuron where it's released, and excites the nerve, which then sends another electrical impulse. It's immediately broken down by cholinesterase. ASE at the end of a word means an enzyme, and cholinesterase breaks it down so you get one signal, one transmission, and it's all over. This is a wonderful safety mechanism. The other thing that's typical of this is that there is very little divergence at the ganglia. So that in this case, one neuron may hit as many as 3 other neurons. That's not very many. It tends to be very carefully focused in where it's going to use the downregulation. So if you look at the slide again, you can see that these nerves coming out, and they hit the ganglion here, maybe 1 or 2 branches, 1 or 2 going on the rest of the way. Same thing down here. And they hit the ganglia way out here in the organ itself. This is what I meant when I said that the ganglia are very far away from the parasympathetic system. For example, this one is actually physically very near the eye. These are all very near the effector organ, and down in the sacral area, they're actually right in the effector organ. So you have a long nerve and then a very short one. If you look on the sympathetic side now, we have a different set of circumstances. The sympathetic system is that fight, flight, fright reaction. And this can be inhibitory, but it's almost always excitatory. It upregulates everything. It's not mediated by acetylcholine. It has a different neurotransmitter across that synapse. It's a drug called norepinephrine. Epinephrine and adrenaline are the same chemical. They're just different names, and I tend to use them interchangeably because you're going to hear them used interchangeably. People don't tend to stick with one or the other. Norepinephrine is just a German acronym. It means nitrogen ohne Radikal, which means nitrogen. It doesn't have a certain chemical radical attached to it the way adrenaline does. You can forget that now. And the differences are very small. A pharmacologist or a physiologist could tell you that the 2 drugs, epinephrine and norepinephrine, have slightly different actions. Just remember that the mediator here is norepinephrine, and it tends to upregulate. As I showed you, it's a thoracolumbar origin in the spine, and there's extreme divergence. These nerves tend to go out at ratios of 1 to 20. So if you look over here, you'll see that what happens is many of these nerves in the sympathetic system can come out here and affect many, many, many different targets further down the line. And when you think about this, this is what we want during an extreme emergency threat on our lives. We want everything upregulated. Now, not only is epinephrine or norepinephrine the neurotransmitter, but some of the fibers of the sympathetic nervous system go out to the adrenal gland itself, where more epinephrine is released into the circulation. So you not only get upregulation from direct neurologic, which we remember now is very speedy and short-acting stimulation, but we also get indirect circulatory chemical going directly to these organs and upregulating them. This is slower. It's more diffuse, since the adrenaline or the epinephrine will go to the entire body, and it's longer lasting because it takes longer to break it down.